Good afternoon. I'd like to thank the moderators and sages for the invitation to present. I have no disclosures except that 8 minutes is really short, so hopefully I can get through it all. So, outline, I'm going to break down barium swallow into preoperative and postoperative indications, and then I'm just briefly going to touch on the indication for gastric emptying. So, first, let's talk about the role of preoperative barium swallow. So, a preoperative barium swallow includes both static and dynamic images and is really used to evaluate structural and functional abnormalities of the esophagus. When building a foregut center, it's important that you talk to your radiologist about the protocol that they have because barium swallows differ a little bit from institution to institution. And I also found it extremely helpful to actually watch them perform the study so you can understand some of the patient positioning and labeling that they put on some of the images that end up being uploaded to your system. So a preoperative barium swallow, the actual only indication is for a patient who has dysphagia. It cannot replace formal pH testing or esophageal manometry testing, but in reality, most of our patients are coming to us with a barium swallow already being performed. So a lot of us are using this as a roadmap to really help with surgical planning. So when interpreting a barium swallow, I think it's important to approach it systematically, and I think that there's really six key areas that you can take away from a preoperative barium swallow. The first is esophageal length. The second is reflux, which really means spontaneous reflux of barium back into a more proximal aspect of the esophagus. Masses or strictures, which can really be a source of dysphagia and can give you some clues as to how severe one's objective reflux may be. The presence or absence of a hiatal hernia, motility, and then diverticula, which also sort of corresponds with an underlying motility disorder. So this is a patient. I'm going to play this quickly and then pause it. This is a preoperative patient, and you can see the flow of contrast through the esophagus. There's the natural sort of, can I go back? Okay, so here you can see my esophagus their esophagus is underneath the diaphragm, so I'm not concerned about their esophageal length. It's hard to replay the video, I think, but they had no spontaneous reflux of contrast back up into a more proximal aspect of the esophagus. I can't appreciate any masses or strictures. Just remember that there's three natural areas where your esophagus is going to have this sort of narrowing, which is expected, and you could see that on this barium swallow. There's no hiatal hernia, and again, their motility looks pretty normal. The contrast flows freely from the esophagus into the stomach. But if you compare this to some abnormal barium swallows, so in the first patient, they have a large hiatal hernia. You actually cannot see the diaphragm at all, and the esophagus is trying to push against the hernia, which is causing a bit of an outlet obstruction. And so you're having spontaneous reflux of contrast back up into the upper part of the esophagus. And then in the second image on the right hand, this is a patient actually that has achalasia, so you'll start to see the distal tapering and bird's beak appearance, and there's no contrast really going into the stomach. So this gives you a little bit of clues to an underlying esophageal motility disorder. Okay, there's three additional adjuncts that I wanted to highlight, and the first is the barium tablet, the second is a time barium swallow, and the third is a barium manometry, because I wasn't sure what else to call it. So a barium tablet is actually routinely performed as part of your preoperative barium swallow, except in patients who have contrast that doesn't clear out of the esophagus. It's typically 12.5 millimeters in size, and the normal diameter of your esophagus is around 30 millimeters. And the barium tablet really helps identify more subtle areas of narrowing in the esophagus. So the first image is a normal study, so the patient swallows their barium tablet and then it just really disappears, and that's what you should see. It should pass freely from the esophagus into the stomach. An abnormal study like this patient, they have achalasia, and so the tablet is getting hung up again in the distal aspect of the esophagus. The time barium esophagram can also give you a little bit of insight into an underlying esophageal motility disorder. So the patient is asked to ingest 150 to 250 cc's of barium. And then the height of the barium column and the esophageal diameter are typically measured at 1, 2, and 5 minutes. Of course, if the barium exits the esophagus in that period, then you don't have markers at a specific 2 or 5 minute time point. At some institutions, they've started calculating the area of the column of barium, and that's because your esophagus is compliant in some cases, and so it can start to accommodate that barium that's sitting there, and so you can be falsely reassured if you're just looking at the actual height of the column. And then barium manometry, again, I wasn't totally sure what to describe this as, but this was actually an oral presentation at SAGES a few years ago, published out of the group at USC. And the barium manometry has a really good correlation with having a normal formal esophageal manometry testing. So they actually found that if this study was negative, that the negative predictive value and sensitivity was about 99%. So there's two parts to this. The first is a patient swallows 5 swallows of 10 cc's of barium in the prone position, and it's considered normal if you have clearance of 3 or more swallows after your first peristaltic wave. The second is the patient takes 5 swallows of either a barium-coated hamburger or marshmallow in the upright position. And normal is considered if there's stasis in less than 3 of the swallows in the distal esophagus. And then you can further grade their degree of abnormalities or esophageal dysmotility, similar to a time barium study, grading by the height of the fluid column and degree of esophageal dilation during this study. So what are some takeaways for preoperative barium swallow? The first is that almost every patient has undergone it by the time they get to you. You should make sure that you're systematically interpreting your barium study and you're using that information to direct additional testing that you think your patient needs prior to getting them to the operating room. So now let's talk about the role of a barium swallow postoperatively. And there's really 2 indications. The first is for a new roadmap looking at postoperative foregut anatomy. And the second is for evaluation of dysphagia or recurrence of one's preoperative symptoms. So a routine postoperative barium swallow, some surgeons get it just as a diagnostic study, so if you're concerned about your patient after surgery, but more times than not, it's being used as a new baseline for foregut anatomy. And if you're using it purely as a new baseline, this is another opportunity to talk to your radiologist. There's several institutions that do this, and it does not delay their discharge, so you're still able to advance their diet. They're not remaining NPO for this study. So I'm interpreting or reading my postoperative barium swallows the same way I do for my preoperative swallows, except I'm doing it in the context of what I expect the anatomy to look like, and also with previous studies. So if this is a patient who's coming back to me with dysphagia and I got it, a barium swallow immediately postoperatively, I'm comparing this new study to any previous postoperative studies that they've obtained. So let's look at some abnormal ones. So this is a patient who came to us with dysphagia. She had a previous Nissen. Again, I can't see the diaphragm here, so her fundoplication is herniated into her chest, and it looks like she's got some sort of distal esophageal dilation, again, just from this sort of like outlet obstruction pattern that's going on. And then the second patient is a patient who actually had a hilar myotomy several years ago. And you can see they still have distal tapering of their esophagus, and now they have a new diverticula, which is consistent with persistent or recurrent achalasia. So a few takeaways for postoperative barium swallow. The first is that there's really 2 main indications. You can get this immediately postoperatively or as needed based on a patient's symptoms at any period throughout their postoperative time. And that the same considerations and systematic review that you use for your preoperative studies, you also want to be using for your postoperative barium swallows. Okay, and then gastric emptying. So there's 2 indications. The first is for a patient who has symptoms and risk factors. So if someone's coming to me with early satiety, nausea, vomiting, they're a diabetic, they're probably going to get a gastric emptying study before their foregut surgery. And then in all of your revisional foregut surgeries, you really want to document the function of the stomach. So a gastric emptying study is performed with a formalized meal. So patients are asked to to eat a radio-labeled liquid egg whites, 2 slices of toasted white bread, 30 grams of jelly, and 120 cc's of water. And they're asked to eat this within 10 minutes, and then you measure the gastric emptying at 1, 2, and 4 hours post-ingestion. The most important point is that there's many medications and other risk factors that can affect your gastric emptying results. So GLP-1 agonists, which we touched on earlier, opioids and marijuana all delay your gastric emptying. Promotility agents, of course, improve gastric emptying. If a patient is coming to you with an esophageal motility disorder, sometimes the meal is stuck at the distal part of the esophagus, and it's interpreted as having delayed gastric emptying. So it's really important that you're looking at these images yourself. And then women who are of reproductive age, you don't want to do it late in their menstrual cycle because progesterone can also delay gastric emptying. So in conclusion, a barium swallow is often the first study used to evaluate foregut symptoms. It cannot replace formal pH testing or esophageal manometry testing. It's indicated in patients with symptoms and who have risk factors and prior to revisional foregut surgery, and you want to take caution when interpreting the results based on patient risk factors for delayed or improved gastric emptying. And that's it.